reach is that we all have anaphylaxis, and that any reaction to an allergy injection may be potential anaphylaxis, even if it's very mild. So even though immunotherapy is the #1 reason for anaphylaxis in most of our offices, those of you that are doing special procedures such as drug challenges or administration of omalizumab may also need to be prepared for anaphylaxis. Our current guidelines recommend 2 hours for the first 3 injections of omalizumab and 30 minutes thereafter.
Y cada 30 minutos en adelante.
Let's get prepared for anaphylaxis. Well, part of getting prepared is getting your staff organized and used to jumping in and knowing their role whenever anaphylaxis begins. We need education. We want our physicians, physician extenders, and nursing staff to be educated.
De enfermería que estén educados.
But we also want other people, our clerical staff and our patients, to be educated. I recommend that each of our medical personnel be up to date with an advanced life support, be it pediatric or adult, and that everyone in the office, including the receptionist, should have completed a basic CPR class. And then we need to educate our patients, whether it's by us sitting down with them or having a videotape. We need to combine that so that the patient knows what to expect and they can advise us of when anaphylaxis occurs. What this cute cartoon shows is this lady thought that eating an apple a day would make her healthy. However, she was allergic to apples, so we have to make sure we are communicating properly to our patients. And you personally need to be involved in that discussion. You cannot delegate to your office staff all of those important matters, particularly when it comes to anaphylaxis and life and death. Be sure the patient understands the risk, the benefit of that treatment, that indeed there's a possibility of death, and that how long this treatment's going to last and what you expect. Do you expect them to wait the 30 minutes that you've asked them to, and what happens if they don't? So you need to spell it out in the very beginning before you start treatment. Then I want you to have mock anaphylaxis drills every 3 to 6 months. How many in the room do this with your staff? You pretend someone's having a bad reaction and they have to jump into action. You really should be. It's so important, because if you don't ever prepare when it comes time to respond, your nursing staff will not be able to do so. The receptionist needs to know her role. She's probably going to call for emergency medical services. The office manager needs to have a conversation with the people in the waiting room so they know what's going on, so they know why they're waiting and why rescue is going to come in the door. And then always provide adequate training to your new staff. Don't accept that they are a nurse and they should know how to do everything and they should recognize the signs of anaphylaxis. And have an anaphylaxis card. I noticed on my way in from the airport that you do have a Home Depot here, just like we do in the States. So I want you to go there and buy a toolkit. It's much cheaper than a medical cart, and you equip it with all the equipment that you will need. It's on rollers, you can push it around the office, and you will be prepared when anaphylaxis comes. If you have loads of money just to throw away, you might want to buy a commercial kit, such as the Banyan, but they're much more expensive. And I have to, I don't need to remind you that these drugs don't last forever. They have to be renewed and refreshed because they have an expiration date. Be sure that you not only set it up, but you inventory it on a regular basis. An expired drug doesn't do you very much good. So have a form have a procedure in the office for updating the emergency card. I think that it's becoming the time and the year that we need to start thinking about having an automatic electrical defibrillator in the office. I personally do have one. I think it's becoming the accepted standard in many areas. In fact, I know in Florida, all of our dental offices, even if you go to have your teeth worked on, they have to have a defibrillator in the office. So again, if it's in all the airports and it's in the shopping malls, and you know you're doing a treatment that's potentially causing death, it's hard to justify not having one. Necessary equipment would include oxygen, IV pole, or something to hang the bag on, perhaps a laryngeal mask for dealing with resuscitation, and a suction cup, along with ambu bags. Then have a plan. The plan can take many different forms. I like an algorithm, and I've shown you an example of that. But there's other kinds of forms that you may want to utilizar. And advancing here. I think the battery is getting weak. And to go along with the algorithm, I use a table of anaphylaxis, which will give me the dosages when I know that I need to deliver that particular drug. Then there's a very simple anaphylaxis plan that we put together for omalizumab in the Joint Task Force paper, and maybe you'd want to use something like that. But then you have to have the plan, but then you have to know where it is. I would recommend posting it in each of the exam rooms, because in the event of a severe reaction, you're not going to be able to relocate that patient. You'll have to start resuscitation at the point of the event. Then let's prevent anaphylaxis. That's the best way, right? So that this does not occur. Critically analyze each patient as you do the allergy skin testing and you consider allergy injection therapy. Remember that not all patients will be candidates either for testing and then particularly for treatment. One guideline is, would they likely survive anaphylaxis? If they are such a fragile medical state, either because of asthma or hypertension or cardiovascular disease, that you don't think they could survive if you had to give them epinephrine, then maybe you shouldn't be treating. Delay starting until the pregnancy ends. Although, as we said earlier, if they're on injections, you may continue. We often ask the question about beta blockers and anaphylaxis. We certainly know that having a patient on a beta blocker, they are at no increased risk for a reaction. However, if we need to treat a reaction, they may be refractory to management. And this can take several different forms. They may have a paradoxical bradycardia. They may have extremely low blood pressure, shock, or they may have severe bronchospasm. So again, various kinds of management problems can occur, but the risk is not extremely high. In fact, the attitude, what we've said in the practice parameter is the draft of the anaphylaxis will say cautious attitude, and that is the same wording that we saw with the immunotherapy practice parameter. Some bodies, such as Gloria, has taken a stronger position, saying that you should avoid beta blockers with all allergy injections. And we felt as we reviewed the data that the newer data really was more supportive of a cautious attitude than total avoidance. In other words, it's not quite so bad. And there's actually been some studies to show a reduced incidence of systemics and severe reactions if you are on a beta blocker. So again, caution, but not, I don't think you have to totally withhold treatment to those patients.
por completo
Now,
el
for ACE
tratamiento a estos
inhibitors
pacientes.
and
Ahora, para los
receptor
inhibidores de la
blockers,
ECA
there's always
y
been a
los
theoretical
bloqueadores de
risk